Hello and welcome to one of our many women's health webinars, what we call WHW. Read it either way, WHW, whether webinar in women's health or otherwise. So the goal of these talks essentially is to provide women appropriate and evidence-based information that you can use to help yourself or help some of your friends, family members, or anybody that you know. You may be in the healthcare field, or you may be just someone who is either suffering from this or knows someone who has these issues. So there are a lot of issues that we will be talking over in the series of talks. Today, specifically, we'll be discussing on this topic called stress incontinence. But let me introduce a little bit about who I am, what we do, and what our practice involves. So it is a big, long word called female pelvic medicine and reconstructive surgery. The abbreviation is FPMRS, and I'm the director of the fellowship program at Beaumont and also the advanced urogynecology practice. Rachel, do you want to advance the slides? Can I?
I can.
All right, thank you. So it is essentially this subspecialty is a very complex and very detailed. It's not urology, neither is it gynecology, nor is it like a hybrid urogynecology. It's a field unto itself. And it is essentially a 3-year subspecialty training after, can you go back? Sorry, thanks. After a 4-year residency in OBGYN. So once a person becomes a full-fledged gynecologist, then after that, you spend 3 more years doing this training. And presently, we have a fellow with us, Dr. Jacqueline Baratono, who is in starting her second year in July. And we hope to continue this fellowship on an ongoing basis. So we take care of all female pelvic floor conditions, which include whether it's bladder conditions such as urine leakage, bladder infections, difficulty emptying the bladder, or whether it's vaginal conditions such as prolapse when things are falling out, or pain or menopausal changes that happen typically after the age of 50. And also bowel conditions, which include bowel leakage, whether it is leakage or constipation, whether it's gas leakage and prolapse of the rectum. So all these conditions that involve the female pelvic floor is what we take care of. So let me ask you at this stage, and I know you can't answer, but if you were to think about this, how common do you think this problem is? Do you think it's like 1 in 50 women have this, 1 in 20 women, 1 in 4 women? So if you were to answer, what do you think is your number? Now that you've thought about it, let's go to the next slide. We'll talk about one condition, and at the end of the session, when we have Q&As, I'll tell you the answer. So today, our topic is stress incontinence. The goal of the talk today is that I'll just be talking over it for just a few minutes, and then I'm going to open it up to Q&As. It's not like a big discourse over an hour. Very short and succinct. Very common problem. This is the leakage that happens with coughing, laughing, and sneezing. It's extremely common, affects at least 1 in 3 women. The other problem with leakage is this gotta-go problem that we'll talk in a subsequent seminar. And then there is a mixed, some stress, some urge. So it's not mental stress. When we say stress, it is physical effort stress. As you can see in this next slide, this is a typical anatomy. In the front, you can see, I don't know if you can see my pointer, but maybe Rachel can point it. The bladder, which is in the front. Then the urethra is the tube that brings the urine to the outside. So that's the little tube, which is just about a 4 centimeter short tube in a woman. Behind that is the vagina. On top of that is the uterus. And behind the uterus is the rectum. So this is the classic orientation in a woman of the pelvic organs. So let's see what happens in the next slide. So when there is a dysfunction, as you can see, the dotted line is where the bladder and the urethra were at rest. As she coughs, typically the dotted line should remain as is. But if there is weakness of the tissue, that urethra tends to fall back. You can see how it fell down. And because it falls down, it loses its support and the urine comes out. So right now I'm standing up, so I'm fine. If I lean back a little bit beyond certain extent, I will fall and I have to hold on to something. So there's nothing to hold on. The ligaments have weakened, and then she gets stress incontinence. Extremely common problem. Next slide, please. So what is the solution for this problem? Should we ever wear pads? I mean, this is what the only solution somehow we know, pads. It's, first of all, this problem is extremely common. So let me ask you the second question. So first I asked you how common these conditions are. The second question, yeah, and you thought this is just going to be a talk, huh? No, it's actually going to be a Q&A. That means I'm going to be asking questions also, maybe a test. So, and some of you know that, yeah, I like to do these things. So the, what is, I mean, is this, so if I were to ask you, is this mainly a problem of the elderly? What do you think? Also, if it is a problem, if you think that it doesn't affect the young people, then what is the ratio? How many more elderly to the young people that you think? Unfortunately, the only solution that women know is pads. You know, it's so strange and so, you know, it is mind-boggling how companies such as, you know, Procter & Gamble and Kimberly-Clark can put up these pads up. And look at this lady. She's young. She looks very healthy. I mean, you can almost see her abs. She's so strong. And she is wearing pull-up pads. But then you wonder, why is she laughing? Why is she smiling and, you know, grinning? You know, I mean, if I were wearing pads and you were wearing pads, you would not be grinning, not be showing off these pads. You said, that's the last thing I want to wear is pads. Who wants to wear pads? And that too, these pull-up diapers. So never wear pads. Pads is never a solution. Can you imagine? Stress incontinence is a medical disease condition, with a medically approved treatment available, like high blood pressure or diabetes. And these companies are hoodwinking women in thinking that pads is the only solution. Think about that. And they make billions of dollars on these pads. And all they come to the level that in this slide, they're showing that, oh, you can wear these pads. They don't even fold. They fit you so well. Can you imagine? This is the level and extent of hoodwinking that's going on in our field of incontinence. That's got to change. Say no to pads, and you'll see how one of our patients did that. Next slide, please. What about bladder suspension? You may have heard the word bladder suspension. So what about that? Bladder suspension, next slide. Just click on it. I can just click on that here. Never to be done. If you go back, never to be done. You know, I have not done a bladder suspension since my fellowship days. I mean, it's over 20 years. It's a invasive procedure, and over time it fails. So bladder suspension, if anybody tells you, oh, I'm going to have a bladder suspension for leakage, that should never be done. Things have changed, and as you can see in the next slide, we now talk about what's called sling procedures. And what is this? Next slide. There are two types of that. One is a long sling, and then there is a tiny sling. So I'll show you what I use now. As you can see in the next slide, there's a very tiny incision made in the vagina. That's it. It's completely under local anesthesia. It's only about a 15 millimeters of fingernail length incision that's made in the vagina. And the sling goes under the urethra, as you can see. Rachel, can you point where the urethra would be? And the sling goes under that urethra. Can you show how it is? And like a hammock, it's supporting it like a hammock, and it attaches to the muscles on each side. And I think if the sling slide, I don't think I have it there, but that's how it supports it. So as you can look in the next slide, you see again, the urethra is that tube. The sling goes like a hammock supporting it. So if that urethra is trying to fall down with every cough, so it goes, now you place the sling and you cough, cannot go anywhere. Supports it, gives it a backstop, and there is no leakage. Next slide. But still, what we found, can you go back? What we found is that there are still some, even though we did this procedure, it still was not that successful. And the reason is, as most of you know, most of these procedures are done with the patient completely asleep. We changed that. About 7 to 8 years ago, we completely revolutionized this by coming up with this acronym called Dynamic Interactive Standing Sling Technique. And I'll tell you, it's called the DIST, and I'll tell you what that means. You can go to the next slide. So this is, we started doing this actually in the office. So now we perform the procedure in the office completely under local anesthesia. Next slide. So I came up with this system where there is this harness bar that Rachel is pointing out. So that's what the patient uses to hold herself. So if you look at it, can you show her how the table is, the OR table, the OR table? So this is where the patient is laying down. The patient is laying down on that table. And can you show that table where she'll be standing up? So that platform down there where she's pointing, that's the platform where the patient will be standing up. So we confirm this success right there during the procedure as the patient is awake and standing up with a full bladder and coughing. So let's see the next slide. So this is exactly what happened. She's standing up, she's holding onto the harness bar, she's completely awake. I am positioning the sling. I have her cough and make sure that she is not leaking. Right there and then, you can confirm success and it's over. So there is nothing left to imagination. There's nothing left to chance. She has a full bladder. So we make sure that we fill her bladder up. Before placing the sling, she is coughing like anything. Now we place the sling, have her stand up. So she's standing, full bladder, coughing, 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 nothing, no leakage at all. If there is any leakage, then I would tension and tighten the sling right there and then. It's literally, if you go to buy a dress, you're not going to walk out. You'll go to the trial room and say, hey, is it the fitting room? Is it fitting me well or not? It may measure the same. It may the size may be the correct size that you wear, but the fit may not be right. That's exactly what we have overcome with this. We have taken away that, is one fit all for the same for all? Absolutely not. Every woman is different. Every pelvis is different. Every cough is different. Every urethra is different. So the tensioning has to be appropriate, commensurate to what that patient's condition is. This is what helps us do that. Next slide. Bottom line, she's fully awake during the procedure. She's chatting with us. It's completely under local. It takes about an hour to do the procedure. She's about an hour in the recovery room, and she's literally back to normal activities the next day with no restrictions from her activities. Initially, I would tell them, yeah, avoid heavy lifting and all that. Now I tell them, go ahead and do whatever you want. There is nothing that's going to loosen or weaken the sling. So literally, they're back to full normal activities the next day. Next slide. So it's highly successful. So think about this. I'll talk to you about our results. Return to work, minimal to no pain. When we ask them, hey, did you have any pain? They say, well, nothing. Maybe I just took a Motrin, if anything. And back to normal activities. So in fact, one of my patients told me, next slide, please. It's like a drive-through sling. It's like you, Dr. Campbell, you just came up with your own McDonald's here. So you just drive by, look at the sling, take it, put it in, and go home. Well, it's sometimes these lines, are so long at one of these drive-through places that, maybe, yeah, the procedure itself takes less time than sitting in one of those McDonald's lines, right? So next slide. Let's hear what one of our patients had to say.
I came to Dr. Cadwalla about having leakage when I cough or lift anything or do anything stressful. It was very, very uncomfortable. It interferes with your lifestyle. You never know what you can do and what you can't do without leaking. And so I had the sling procedure done, and now since the sling procedure, I have no leakage whatsoever. When I got to the hospital to have it done, the nurses were all very attentive. They were very nice. The procedure itself in the operating room, all the nurses were there. There was very little pain. You're awake through the whole thing. And after the procedure, I have had no problems whatsoever. I have no leakage whatsoever. And it makes a huge difference in your lifestyle.
The bottom line, this is what I hear almost every day with every case. It has changed things. And the reason why it's changed is because the way we do it. So let me tell you, let me ask you this. The next question I'll ask you is this. When you go for a procedure or go to see a doctor, whether it's for gallbladder or some kidney stone, whatever you may have, do you ever ask the doctor, so tell me, doctor, what is your experience? Sometimes you may, hey, doctor, what's your experience? And the doctor will typically say, oh, I've never had a problem. But do you ever ask your doctor, doctor, can you show me the evidence? Do you have this published? What are your actual numbers of success? What is your risk of complications? Have you ever published this information? We never ask our doctors that question. And probably most of these doctors don't know that. So if I say that, oh yeah, in my hands, everything is great, how do I know? A patient could have come to me, had a procedure with me, and now she's unhappy and she's gone somewhere else. I would never know that, because she never came back to me. But what we do in our practice is we seek evidence. So we track our data. So this is what we saw in our results. We have actually published 2 papers, and the first was published in 2019, and it showed 97.4% success, no complications in 78 patients studied in this particular study. And in the other one, where we did the procedure in the office, completely awake, it was 95% success. The patients were dry and no complications. Next slide. I don't know what these lines are coming up there, but nonetheless. So so now we are doing 2 other studies. We are following these patients who had done in the office, and we're tracking them over time, and we're following them at 2 years, then 5 years. So if you came and asked me, so Dr. Kandwala, tell me your results, and I'll tell you, well, this is what our results were, 97% success. That's what we've published. That's what our patients have told us. But now I'll tell you what we've seen over time. That's about 5 years and beyond. So that's our next step. So that's what we're looking at. And we're also, any patient who has the sling procedure done, we track them, we follow them, we make sure they're doing how they're doing at 3 months, 6 months, 12 months and onwards. So if you came to me and asked me, tell me your results, well, I can tell you. And we have the evidence to show that. Next slide, please. So why is it then, if our success is 97% and the published success is only 60 to 65%, why is this success so different? And you figured it out. It's because we tested right there and then. There's nothing left to chance. She's not asleep. I put it in. To me, it looks okay. But is it really okay for her? I don't know until she gives that first cough when she wakes up and is home. By that time, it's too late. She's already home. I cannot do anything then. But with my procedure, I can do it right there and then. She coughs and she leaks. I tighten it until she does not leak anymore. So success is immediately confirmed. And we have then seen that if you follow these patients over time, that success persists and remains as good. Next slide, please. So now tell me this. If I told you all that information, how high the success is, there is no or extremely low risk of complications, minimal to no pain, going back to work the next day, why then should any woman continue to leak with coughing, laughing, and sneezing? It makes no sense, right? So why should we therefore not take control or tell women that this is something that you should not be living with? Forget pads. Why would a woman who's 30-year-old be wearing pads for 50 years? It just makes no sense. And that is because they don't know this information. Once they understand this information, remember this, it's nothing to do with embarrassment. It's not embarrassment that's preventing them from seeking treatment. It is ignorance. The lack of what can be done to help this problem is what prevents them from coming for care. Simple as that. Within 5 minutes, I do not know this patient at all. Within 5 minutes, I know her whole history. How come she tells me everything within 5 minutes? Because she's fed up. It's on the tip of her tongue. I want this to be taken care of. And the sad part is they'll go here, they'll go there, and they just don't get the right answer. And they then count on pads. Next slide, please. Let's see one more patient, what she tells us.
I came to Dr. Kandwala a couple years ago in regards to my stress incontinence, and I actually decided to not do it at that time for whatever reason. I just got nervous or whatnot, and then it got worse through the time, my bladder leaking, and I decided that I was either too young or I just didn't want to deal with having to wear a pad anymore, whether I laugh or even scream, raise my voice, even I would yell or whatever, I would actually leak as well, coughing, sneezing. And I went through the procedure and it was amazing. The staff, I can't even describe how amazing they were other than they were amazing. Very compassionate and knowledgeable, both at the office and at the hospital. In the operating room, and it was a breeze, and I'm very glad it happened and that I did it. I was laughing and talking to a friend, and I turned to her and I put my thumb up and I said it was a success because I didn't leak actually. And there was a little moment and she was kind of looking at me, and I explained to her what I had just done, that I had that surgery. And she said, you have to send me his information. So I recommend it to anybody if you're having this problem to give Dr. Kendall a call.
Or more importantly, it doesn't matter who you call. It's the fact that you must get it taken care of. So that's what, when Gandhi said, be the change you want to see in the world, what I would tell you is, next slide, please. Be the change you want to see in yourself, or a close family member. So why not just be in glee, just jump, do what you want to do? Why should a woman take, these bypasses and not run, not jump on the trampoline, not play with the kids, not do things like, kickboxing, Zumba, things that she loves to do? Why would she have to circumvent all that and give up all that for a condition that can be so easily taken care of? This patient that you just heard about, well, her problem is that when she was told, and her gynecologist is telling her, why do you want this done? You're too young, just do Kegel exercises. And she just got scared and she waited. And then she told me afterwards, I don't understand. Why did I wait? I'm so sorry for waiting. And that's the most common regret of our patients. Why did I ever wait? And now they know this stuff. They say, forget about it. I don't want to deal with this. I'm bothered by this. I want to get it taken care of. So let's see what we have now created and what I encourage my patients to do. All women who have pads, this is what they now do.
Thanks to Dr. Khandwala and his disc procedure, I don't need these pads anymore.
So you can join our pad burning club. If you don't need any pads, throw them in the fire pit. Get rid of the pads. We have a little competition coming up. Who can, with the NBA finals coming on, who can put the pads through the hoop. So you do not need to be living with this, or anybody else for that matter. So what are the goals of this talk today? Several. Number one, it's an extremely common problem. Number two, it affects everybody, young or old, it doesn't matter. It's a medical condition. Number three, it's not about embarrassment. It is about awareness. You talk about it. Why would a woman not talk to another woman about it? Say, hey, do you have this problem? It's like if you ask me, how's your blood pressure? Why would you not say, hey, how's your incontinence? And the person says, oh, it's fantastic. I don't leak anymore. So what's wrong in that conversation? It's not you're not saying anything bad. It's a fact of life that, just because you had a child and there was and because the baby came through and there's pelvic floor trauma, injury, and you had incontinence. Now, is that something that you should be guilty about? So why not open up, talk about it? Now, here in this group, we have a recording of this and send it out. And our goal is to really disseminate this information. So that said, I'm going to open it up to question and answers. And Rachel may have already received some questions. And so let's get it open. And then you please send some of the questions if you need.
Okay, yes, Dr. Khandwala, thank you so much for that great talk. I do have a couple questions here. And like you said, if anybody wants to submit any more, they can go ahead and do that. The first question I have is, why do women wait so long to take care of these conditions?
So I wonder, so if I ask the audience if they could answer, unfortunately it's all virtual now and it's not live, but if I were to ask, I wonder what they would tell me. Why do they wait? Why does a woman wait so long? And I think I've sort of answered that question. The main reason is because they just do not know. And all they see is what? Ads on pads. That's it. There is nothing. There is no information coming from doctors like me saying that this is a procedure that you should do. You don't have the time. We are busy practicing. We come home to our family, we do our thing, and then go back to work again. We don't have this time that what we are planning to take in our practice and increase awareness. Our goal is just to increase awareness. It doesn't matter where a woman goes to get treatment, as long as they're aware as to what can be done about this. So the main reason is that they don't know why and what can be done. And that's the most frustrating part for me when I see my patients. Why are you suffering from this? Would you do that if you could not see and had blurred vision? And would you wait a few years before you got the treatment done? Absolutely not. You'll say, oh my God, why can't I see? What's wrong? I've got cataract, I've got some retinal problem. You'll get your eyes checked out. So why would you not do the same thing with the pelvic floor?
I think you kind of touched on this next one, but why don't doctors tell patients more about what can be done about incontinence?
Well, the truth, you want to know the truth, is that they don't know. Remember, these are doctors who finished their medical education about 20 plus years ago. And now they're just dealing with whether it's high blood pressure, diabetes, or just obstetrics and pregnancy. So they don't even know what I'm telling you. No, very few doctors, and that's our mistake too. Very few doctors know about what I'm talking about, this particular procedure. So if they don't know, what are they going to tell you? They still use the word bladder suspension for our patients when this is an archaic operation. Hasn't been done for decades, and they're still talking about it. So that's number one, they don't know about it. And number two, they feel that their lack of knowledge then translates into the patients, and where they say, oh, why do you want to have a procedure done? Did you not read about this information on mesh and slings? What was in the media? So they gave wrong information. Patient goes with this rather than now they can go to our website, look at the truth, the facts, and the evidence, and then they can challenge and say, no, I saw this thing, this is what exists, doctor, do you know about it? And they may say, I'm sorry, I don't know, but if that's the case, I'm sure they will not prevent you from going for that treatment.
Okay, the next one, this lady says that her friend had a procedure done for stress incontinence, a sling, and she's still having leakage. So how effective is the sling?
So that's, that's a good question, actually, because ultimately, it is the way to do it. Like what I mentioned, if she's asleep and the sling is placed, you don't know how tight to make it. So then the sling gets blamed. Oh, the sling doesn't work. And even doctors blame the sling and say, yep, this is useless. Let's not use it. Let's go to the next thing. It's not about the sling. It's why. And as I mentioned, every patient is different, and the sling tensioning is very individualized. And that's exactly what we do. It takes me a good bit longer to do the procedure. I could do it in about 5 or 10 minutes. Here it takes me about 40 minutes to do it. But if we are very careful, we are very meticulous. We do this under local anesthesia. I don't want her to feel any pain. The main thing is, can I have her stand up and cough with a full bladder and not leak? But if she can do that, that's it. It's over. So that is our ultimate goal to do.
So this woman, this is a good question. Will the sling affect my sex life?
Yeah, so people think that, oh, I have my G-spot there, will it affect it because you're making an incision right in the vagina? There are papers that have been published on this, and what they found is that the sexual function actually gets better after the sling. I mean, think about this. During intercourse, many of these patients are actually leaking urine during sex. So who wants to have sex and leak on your partner? It doesn't matter if your husband is recently married or you've been married for 20 years. You don't want to be leaking on your partner during intercourse. When that ceases and you're not leaking anymore, sexual function becomes enjoyable. So the fact is that, and what's published, is that sexual function, in fact, improves after a sling rather than any concerns with intercourse.
One
more thing. Remember, the sling is in between the vagina and the urethra. It's not dangling in the vagina. So like one of my patients was joking with me and saying, hey, is it like a fish net that's going to catch him or something like that? I said, no, it's in between. So it's nowhere in the vagina. It's like, the wires behind the wall. You cannot see the wires. The wall is nice and smooth. That's exactly how the sling is in between. Sorry, go ahead, Rachel. What's next?
Is it covered by insurance?
I don't know the answer exactly to that. Well, it all depends upon what your insurance is, but absolutely, this is a medical condition like any other. So if you're going to have a gallbladder taken out, it's the same thing. No difference. So it's not a cosmetic procedure.
Okay, so if a doctor does the sling procedure without your technique, will it work?
It could work, but then you don't know until she goes home and coughs, whether it's going to be successful or not. You want to it's literally what I tell my patients and what I have on my website. It's almost like you're going through a procedure. Would you not want to make sure that it's successful? Like if a woman is getting married, will she just get her bridal dress delivered straight to a place of where she's getting married, or will she actually trial it out? Who does not trial it out? So the same thing here. Why not trial it out and check it out right there and then and confirm its success? And that's what we found. If any and every time we confirm success during the procedure, everybody has been a success. It's crazy. And we hardly, almost never see a failure thereafter. I mean, people almost may think that my colleagues may think that I'm lying. That's how high our success rate is, but it makes total sense because we actually confirming it right there and then.
Okay, here's another one from somebody. What are the ends of the sling attached to? It
has a very nice contraption at the end. It's almost like a little bit of an arrow that goes into. It's like when you put a screw into a wall and hang a mirror, something like that. It's very tiny and it goes into the muscle and holds up beautifully. The tension is unbelievable and the strength of it once you put it in. It's almost impossible for the woman to do anything to weaken it. So the follow-up answer to this is, does the sling loosen over time? The sling does not loosen at all. Once it's placed, it takes me so much effort. Even if I have to, let's say I put it in and she's still leaking and I want to replace it, to take it out, it's so hard to remove it. That's how beautifully it goes into those muscles and it stays put. So it's not the sling that loosens, but over time, if you don't keep your pelvic muscles strong, then yes, the sling will loosen indirectly because your muscles weaken. So we make sure that our patients keep doing those muscle exercises ongoing after that.
Can the sling cause any reactions? Can you be allergic to it, or can your body, not kind of reject it? Or, or anything like that?
You're getting a lot of questions on this topic, So, this material is called proline and has been like a suture since 1960s. And it has been found to be inert, no concerns of reaction, no risk of cancer. And the same material has been made into like a ping pong netting. That's what it is. It's literally 8 centimeters long and 1 centimeter wide. That's how tiny this thing is. So there's zero chance of any reaction happening to this material. And at any given time, there are thousands of doctors who are using this thread, that makes up the sling. So this whole thing that came up about in the media about, oh my God, the sling is bad, the mesh is bad, should not be used. Well, we know why that happened. That was a totally different reason. Lawyers just taking it to another level. Each and every medical society that deals with slings or incontinence across the globe, each and every unanimously have said, and not me saying it, each and every society has said that the sling is safe and effective. There's no concern with the sling. So forget about all this. It's lawyers touting what they were doing a few years ago. No concerns. Every society across the globe says the same thing. So the sling, the key thing is who is doing the sling, why is it being done, for what reason, and what is the technique. And if you do it right and you know how to do it, then it's extremely successful with almost no complications. Actually, you're muted.
Yep, sorry. That's all the questions we have right now, other than the last question I've gotten is, we haven't talked about bowel incontinence. What can be done with that? Which is a great lead into what our next talk is going to be about, which is fecal incontinence.
Yep. Yeah, so there are different types, and of course there is this urgency leakage also. Gotta go. So remember, the sling is designed and indicated for leakage with laughing, coughing, and sneezing. Nothing to do with urgency. So if you have that gotta go problem, the sling is not going to work. So if you have a mixed problems, coughing, laughing, sneezing, leakage, and urgency leakage, well, it's going to take care of one. It's not going to take care of the other. The other treatment is completely different. So remember that. That's one. Second, bowel leakage. The sling is not going to help you with the bowel leakage. That's a completely different topic. Extremely common, whether it's gas leakage, you're going in a boat pose in yoga, or you're doing something and you're losing gas very easily, and you say, oops, it's crazy how embarrassing it is to just lose gas. There's so much that can be done about it, but Rachel, that's a good segue. That's what we're going to be talking about next time. It's very common. So let me see. I don't know if they answered it in the chat or something like that. So I think let's see, before we wrap up, let's look at those answers. So how common are these conditions? Did you get the answer, Rachel? Anybody answer?
No.
Well, it's 1 in 2 women that we know. 1 in 2 women have at least or will suffer from at least one of these conditions. So if there are 15 women in the audience of 20 women, and at least 10 women will have it or may get it. So it's very high, but it doesn't matter. You know, it's something can be done about it. You know, for men balding, there's nothing can be done about it. You know, graying of the hair, you cannot really, maybe you can dye your hair, but here we can correct the problem. We have solutions which are absolutely authenticated with full evidence that these things work. So that's number 1. The second question I think I asked was, I'm not forgetting, what did I ask the audience? Elderly age. It could affect any age. So it is a misperception that this is a problem of the older women. Absolutely not. It's just women just deal with it. And why? And that's what I told you. It's the lack of awareness. Now, once you're aware of it, I mean, you really have to wonder now. If a patient knows what can be done about it, it doesn't cause any discomfort or pain, there's almost 100% chance of fixing it, 0% chance of complication. I mean, then why am I waiting? Why am I wearing a pad? What does the pad do? It doesn't correct the problem. It just hides it. That's it. Just hides it. You know, so why would you hide it? Now, it's like, suppose if I have a problem with my eye, like my cornea, my eye is getting red all the time. Should I just keep wearing sunglasses, or should I actually go and show it to an eye doctor and say, hey, what's wrong? Why is my eye getting red all the time? You're not going to put just sunshades on. So why are you putting a pad on? So your job, your goal is to help me get this message through. I cannot do it alone. You know, I need women to empower women. And that's what this whole seminars, all these seminars are about. Well, thank you so much for joining in today. And I look forward to talking about this on bowel leakage next time. So Rachel, when is that?
That is July 13th.
All right. So note it down in a calendar. July 13th. Is it the same time, Rachel?
Yep.
So July 13th at 6 p.m. we shall be talking about bowel leakage. Until then, spread the word. No pads. Go join the pad burning party and stay dry, be dry. Take care.